It is the 23rd of August 2020. There are more than 3 million cases in India with 56,000 deaths. The situation in Delhi is quite stable. We have about 1.6 lakh cases with 4,300 deaths. The serology report, which has come in recently, has been very reassuring. Almost 30% of Delhi's population has antibodies to this virus, which means that about 65 lakh people have been infected, keeping in mind that the population of Delhi is about 200 lakhs. Now, this means the infection fatality rate is down to just 0.06%. I will repeat that. The infection fatality rate in Delhi is as low as 0.06%, which is really very, very low. Nothing to be alarmed about. Now, keep in mind that a few weeks ago, most health experts of this country were shouting at the top of their voices that there would be 5 lakh or more cases in Delhi by August. Well, that has not happened. In fact, the cases have been waning, they have been declining. In June, on a particular day, there were almost 4,000 new cases, whereas yesterday there were 1,400 cases, which means there is a definite decline in the number of cases of COVID-19. And in Delhi, in a single day, almost 20,000 tests are being done, of which 6,000 to 7,000 are the RT-PCR variety, and the rapid antigen tests are to the tune of 13,000. So the important news is that almost 30% of the residents of Delhi have become seropositive. That means they have antibodies, which means they have been infected in the past, which means that about 65 lakh people have been infected. And the situation is pretty good also in Pune, where these tests have been done. In Pune, it seems that about 51% of the population has been infected already. Now, if you have 51% of the population already infected and having antibodies to the China virus, this means that even Pune is heading very quickly towards herd immunity. Herd immunity, as I have already mentioned earlier, is a point wherein the virus can find no more new culprits or no more new victims actually to infect. Now, the mathematical modelers have told us on a theoretical R value that this would be about 70%. But in actuality, this is much less and has to be less than 50%. It should be to the tune of 40% or even lower, maybe 30%. And even this I have been harping on for the last so many weeks. Now let us take Delhi. For instance, the number of cases have been declining. From 4,000, they've come down to 1,400 per day, which means that there is a decline of almost 60%. Now this cannot happen if there was no sign of herd immunity. Now remember that apart from the antibodies, the human body also manufactures T cells, which act against the cells already infected by this virus. And the number of people who have T cells is also very large. A recent Swedish study has once again shown that apart from antibodies which are produced against even mild infection, because we have to keep in mind that 80 to 85% of these people are either asymptomatic or have mild infection. So the Swedish study, apart from other studies, have clearly shown that even mild infection boosts antibodies, and these antibodies are present for some months, at least for 3 to 4 months. And apart from the antibodies, which is most important, is the fact that their body also produces T cells. Now, these T cells also act against the virus. We already know that SARS-1 and MERS have antibodies for as long as 2 years, and we know for a fact that after SARS, T cells acting against future infection by SARS-CoV-1 virus have been around for almost 17 years. So one can, of course, not say emphatically, but one can make a safe presumption that even in SARS-CoV-2, or rather the China virus infection, T cells which are produced should last for at least some years, if not for 15 or more than that. Now, these facts are very reassuring because you don't have to make a very, very strong pitch for a vaccine. It does make sense, of course, that a vaccine would be of great help. But once we have 1/3 of the population already infected by this virus, and these people have made antibodies, it is a different matter whether these antibodies are neutralizing. I will come to that very soon. But the fact is that 1/3 of the population has already been infected, and the proof of the pudding is in the eating, and that is the number of cases are declining. The number of deaths per day are now sometimes in single digits or only in two digits, which means about 10 to 14 people have died because of COVID-19 on a single day in the past fortnight. The situation in Dharavi is also excellent because Dharavi, as you know, is one of the largest slum areas in Asia. In an area of only 2.6 square kilometers, there are more than 10 lakh people living. And the serology tests from there have shown that almost 57 to 58% people have already been infected. So I would presume that Dharavi has hit herd immunity, because apart from the 50% or 58% who have antibodies, about 20 or 25% more would definitely be having T cells also against the China virus. So Dharavi is pretty safe. And that is why yesterday or the day before, only 3 or 4 people died because of COVID-19. And even these figures can be scrutinized, because we really don't know whether these people have died because of COVID-19 or because COVID-19 was present during, or because of a death due to some other cause. So we have a flurry of papers published recently. These are, of course, already peer-reviewed, and some are not peer-reviewed, but they are all suggesting that even mild infection, we know that severe infection definitely produces antibodies against the China virus, but these papers are suggesting that even mild corona infection does produce antibodies which do last for some time. Now remember that we have the IgM and the IgG variety of antibodies. The more important or the longer lasting ones are the IgG. Even here we have two subsets. We have antibodies which are targeting the nucleocapsid of the virus, and we have antibodies which are targeting the spike. I will make that simple for you. Simply knowing about an antibody is not enough. We must check for the antibody which is targeting the spike, because that is more important. The antibody which targets the spike of the virus is the one which will block further infection. Now Roche initially has made assays, has made antibody tests which are targeting the nucleocapsid. Now these are not of much value because nucleocapsid antibodies decline very quickly and also are not so powerful. But now Roche has decided to make assays which will target the spike part of the China virus. Not only that, Roche and Siemens and other companies are now coming up with tests that not only detect the presence of antibodies, but also the titers of these antibodies, which means the quantum or the quantity of these antibodies, or rather they detect neutralizing antibodies, that is NABs. Now NABs are neutralizing antibodies. Once you have a neutralizing antibody in your system, you can be sure that you will prevent a future infection. Now this, of course, is still not very clear with the natural infections where COVID-19 is concerned, but that is the same situation, or would be, with the vaccines. We don't know whether the vaccines will produce adequate antibodies. Of course, the phase 1 and phase 2 trials have suggested that neutralizing antibodies are being produced, but we don't know how long these antibodies will last. Keeping in mind that vaccination against diphtheria is effective for almost 17 years. Vaccination against tetanus is effective for 11 years, and vaccination against the measles virus is effective for almost a lifetime. We still do not know how long the immunity that will be produced by these vaccines will last. But again, the reassuring fact is that all researchers from different parts of the world have suggested quite strongly that apart from the antibodies, we also have T cells, and these T cells can last for a long time, and they are also very effective in fighting against the virus. A paper from Seattle has been published again very recently, which has convincingly shown that people with mild infections do develop antibodies, they develop T cells, and also apart from the antibodies and T cells, they also develop what are called memory T and B cells. This means that even if the levels of these antibodies or T cells have declined to a large extent, they still have the capacity or the memory to boost up antibody production in the event of a future infection. So the news is reassuring. First of all, in Delhi, the infection fatality rate is just 0.06 or 0.07%, which is remarkably low. And we also have information, scientific data, supporting the fact that apart from antibodies, we also make T cells. And we know that in Delhi already 30% of the population has developed antibodies, which means 30% of the population has been infected. And we don't need 100% population to be infected to hit herd immunity. As I've said again and again and again, herd immunity could possibly be achieved at just 30, 35 or 40% infection. So if we have 30% infected and 30% people having antibodies against the China virus, we can presume that another 30% or at least another 20% would be having T cells, which would mean that 50 to 60% of Delhi's population is adequately immunized. Now we come to the vaccine itself. The vaccine, we have two basic types of vaccines. One is called the antigenic immune vaccines, and the others are the traditional vaccines, which are the protein immune vaccines. I have already mentioned about the genetic vaccines, which are the messenger RNA vaccine being made by Moderna. Animal trials have been done, and they have shown successful development of antibodies, plus successful check on a future infection in monkeys. They have also done placebo-controlled trials in people. They have done phase 1 and phase 2 trials. Once again, they have shown that there are adequate antibodies. They are of the neutralizing antibody kind, but we don't know what is the duration or the durability of these antibodies. That would be confirmed by the phase 3 trials, which have already begun, and that would include in the Moderna trial almost 30 to 35,000 participants. Apart from the messenger RNA, the other genetic vaccine has been developed and is being tested by the Oxford group, and this will also be tested in India. That again will include more than 30,000 participants. The vaccine has been shown to be effective in animals in the sense that it prevents serious infection, and phase 1, phase 2 trials have shown that the vaccine does produce antibodies and the vaccine is reasonably safe. Now we come to the traditional vaccine. The traditional vaccines, which are vaccines made from viruses which have been inactivated by certain chemicals. And the vaccine I'm going to talk about has been, the data has been published in JAMA again a couple of days ago by the Chinese. They have done a phase 1 and phase 2 trials which have included 300 participants. They have used an inactivated vaccine, which means they took the virus, they took the China virus and inactivated it. That means it is no longer toxic. They inactivated it by a chemical called propiolactone, which is very effective. And plus they added a booster, which is alum. The aluminium makes the vaccine more powerful. That gives it gives it the potential to elicit more antibodies. Now the results are in, as I've said, they have been published in JAMA, and the results are clear that the vaccine does produce neutralizing antibodies, and more importantly, the vaccine is safe. The percentage of people who had adverse effects in this trial were just about 14 to 15%, and these adverse effects were pretty mild. They were largely pain at the site of injection, or some fever and some fatigability. And these were easily tackled by paracetamol, or they just went away. So the inactivated vaccine, we have them also. We have them for hepatitis A. We have them for the Salk polio vaccine. These have been used again for years. They are the traditional vaccines. And even in India, there is a company in Hyderabad which is called Bharat Biotech, which is collaborating with the ICMR to make the inactivated vaccine. The results of this Indian trial, the phase 1, I don't think has been published as yet, but one would presume that it would be published soon. And the fact remains that traditional vaccines have been with us for a long time, whereas the genetic vaccine, that is the messenger RNA or the adenovirus vector vaccines, are yet to be used in human beings. So we all wait with bated breath about the results of the phase 3 trials with the messenger RNA vaccine and the adenovector vaccine, plus the inactivated vaccine, which I have just spoken to you about. Now, apart from vaccines, the fact is that we are now able to manage these patients much better than we were doing in April and May. The reason is simple. We have become more familiar with the symptomatology of the virus, the presentation of the disease, and we also have some drugs at our disposal which are effective. And of course, I cannot but mention dexamethasone, that is a steroid which has been shown in a randomized trial that included 6,000 patients, in fact more than 6,000 patients, and these were serious patients. And this trial was done by the Oxford University, supervised by the Oxford University, and this showed clearly that there was a reduction in mortality which was significant in patients on ventilators by about 30%. The mortality was reduced from 40% to 30%. Also, Dexa reduced mortality in patients on supplemental oxygen from 26 to about 22%. That is a reduction of 20%. Now, this is very important because this is the first drug which has been shown to reduce mortality significantly in patients with COVID-19. Now, apart from that, I must again talk about Remdesivir because a study has been published just 2 days back. This is again a randomized trial. There have been 3 randomized trials on Remdesivir. The first was done in China, which included about some 230 patients of COVID-19 who were confirmed by RT-PCR and radiological changes on X-ray and CT scan, plus the fact that they had an oxygen saturation of less than 94%. What the Chinese found was that there was no significant difference in mortality between a placebo and Remdesivir, which was given for almost 10 days in these patients. There was, of course, a shortening in recovery time. But after the Chinese data, there was another big randomized trial which was published in the NEJM, and this had more than 1,000 patients of COVID-19. Of these 1,060 patients of COVID-19, I think 25% of patients were on a ventilator, 20% of patients were on non-invasive high oxygen therapy, and 40% were on supplemental oxygen, which means this was a group. These were patients of moderately severe COVID-19. The result was that recovery was reduced from 15 days to 11 days, which was significant. There was a trend towards lower mortality from 11% to about 7.2%. However, there was no significant reduction in mortality. Now, the study which has come in about 2 days back has about 600 patients of COVID-19. 200 were given Remdesivir for 5 days. 200 were given Remdesivir for 10 days, and 200 were on the usual supportive therapy for COVID-19. Once again, we did not find a significant reduction in mortality with Remdesivir. However, on the 11th day, the 5-day regimen of Remdesivir did show better clinical outcomes than the control group or the 10-day Remdesivir group. So, to cut a long story short, what we find with Remdesivir is that it does reduce recovery time by some days, but it is yet to show a significant reduction in the death rate in patients of COVID-19. Now, I raised this point about the insignificant reduction in mortality because the drug is priced very high. In the United States, I believe that a total cost will cost about $3,200, which is about 2 lakh rupees. Now that's a huge cost. In India, the average cost per ampule is of 100 milligrams is about 3,500 rupees. Zydus Cadila has come up with the lowest rate of 2,800 rupees per vial of 100 milligrams. Now remember, the drug has to be used at least for 5 days or 7 days. So that would be about 15,000 rupees. Now a drug which has failed to show a significant reduction in mortality should really not be priced so much. That is my personal opinion. Of course, this is subject to discussion. The interesting thing in the study which was published 2 days back in JAMA is that Remdesivir in the 5-day therapy group of patients was superior in terms of clinical outcomes as compared to the supportive group, which was again about 200 patients. So 200 patients of Remdesivir had superior clinical outcomes at 11 days as compared to the supportive therapy group, despite the fact, now listen to me very carefully, despite the fact that 45% of the patients in the supportive therapy received hydroxychloroquine, whereas only 8% of patients in the 5-day Remdesivir regimen received hydroxychloroquine. So of course, one cannot make any firm conclusions, but the signal is clear that hydroxychloroquine does not work in patients of mild COVID-19. I forgot to mention that the study which was published 2 days back included patients who had COVID-19 confirmed by RT-PCR, and also they had radiological changes. That means they had changes on their X-ray and the CT scan, but they managed to have an oxygen saturation of 94% or above on ambient air. So these people were of the mild or moderate infection variety. So I repeat, hydroxychloroquine was given in the supportive group of 200 people to the tune of 45%. 45% of people in the supportive group received hydroxychloroquine, whereas only 8% of patients in the Remdesivir group received hydroxychloroquine, yet Remdesivir outperformed the supportive group with hydroxychloroquine. Now, hydroxychloroquine, we have very few randomized trials. I will mention 3 of them. I have already mentioned these. One is the post-exposure hydroxychloroquine randomized trial, which had about 600 participants and showed that the participants who had been exposed to a definite or probable case of COVID-19, hydroxychloroquine did not prevent the onset of infection, did not prevent any infection of COVID-19 in these people. So as a post-exposure prophylactic, hydroxychloroquine has not worked in a randomized trial. The other randomized trial was the big study, the recovery trial, which had again more than 4,000 patients, and these were moderate to severe. And once again, it was seen that hydroxychloroquine did not reduce mortality. In fact, recovery time was shown to be increased with hydroxychloroquine versus supportive therapy. The other trial, the third trial, the randomized third trial on hydroxychloroquine has about 600 people, I think, 600 patients, and this has come from Brazil. Here they took mild patients of COVID-19, patients who did not require oxygen more than 2 liters per minute, and showed that clinical outcomes did not differ in patients who were receiving hydroxychloroquine as opposed to the supportive therapy group. Now, I will end this talk by highlighting the All India Institute of Medical Sciences grand rounds on COVID-19. So they've had 4 grand rounds which are present on YouTube. Grand round 3 was on the use of oxygen and convalescent plasma. I have already spoken on convalescent plasma some days ago. But the interesting thing I found in this COVID-19 grand round by AIIMS was that they presented a lady of 35 years who happens to be a doctor who had a severe bout of COVID-19. And this lady, interestingly, was also suffering from a non-specific autoimmune disease for which she was already on hydroxychloroquine. So despite the fact that she was on hydroxychloroquine as treatment for an autoimmune disease, she went on to develop not only COVID-19, but a very severe form of COVID-19, which required high flow oxygen by cannula, which required antibiotics like meropenem and teicoplanin, and she also received tocilizumab apart from 2 doses of convalescent plasma. The good news is that the patient, the lady, is doing well. She is well on her way to recovery. But the point I want to make is, here is, of course, this is an anecdote. We have a young lady who is already on hydroxychloroquine as treatment for a non-specific autoimmune disease. Despite the hydroxychloroquine, she developed severe COVID-19. And this reminds me, I think I have already mentioned this, there is a Spanish trial also, which had included some 200 or 400 people of autoimmune disease, specific autoimmune disease such as rheumatoid arthritis and lupus erythematosus, SLE, and they divided, or rather picked up, they compared the patients who were on hydroxychloroquine as opposed to those who were not on hydroxychloroquine, and found that in their follow-up there was no difference in new infections of COVID-19 in the people who were already, in the patients who were already on COVID-19 as opposed to those who were not. So I will sum up this talk of today. That is, we are heading towards good times. The number of cases in Delhi are declining and have declined significantly. More and more people are becoming seropositive, which means to me that more than 50% of people have antibodies plus have T cells, and this immunity should last for more than a couple of years, regardless of what doomsayers speak about. And the best thing is that in reality, as opposed to the predictions made in the recent past and the distant past, that there would be lakhs of patients of COVID-19 in Delhi by August and the hospitals would be totally swamped by these cases, that is not the case. People are coming about, people are recovering, and people are having significant amount of antibodies. But this does not mean that we become complacent. We have to follow the simple rules that we do not go to crowds, we avoid bazaars. In the event that we have to go to a bazaar or we have to go to a crowded market, it is best to wear a mask. It is best to stay away some distance, 4 or 5 or 6 feet from people you do not know. And it is important that we keep washing hands as frequently as possible in a day. With this, I will finish, and of course once again highlight the fact that randomized trials with hydroxychloroquine have not shown great efficacy. Remdesivir is a drug which can reduce the days of symptoms, but is yet to show a significant reduction in mortality. The only drug so far we have which has shown a significant reduction in mortality is dexamethasone, which can be given orally or which can be given by intravenously, and the dose is 6 milligrams, but this should be used only in patients who require oxygen for their disease. Thank you very much. I hope you subscribe to this channel, and in order to subscribe to this channel, you press the bell icon. Thank you very much. Goodbye.